Good afternoon, and thank you for joining us today. My name is Darcy Belito de Luna with the AIUM, and I will be your host today. As part of our continuing education for healthcare professionals, I am pleased to host this webinar on echocardiography, presented by Drs. Rachel Liu and Ritu Thaman. Today's webinar will cover identifying cardiac manifestations of COVID-19, how those manifestations may appear on point-of-care echocardiography, and explain cardiac focus differences in various care settings. For more information about this webinar, please visit the webinar listing in the AIUM Education Center on our website. If you have questions for the presenters during this webinar, you may type them into the Q&A box at the bottom of your screen. You will be able to submit the questions throughout this webinar, but the presenters will not begin answering questions until they have completed their presentations, at which time they will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'd like to begin this presentation with Dr. Rachel Liu.
Hi, thanks for attending this webinar. As Darcy said, my name is Rachel Liu, and I'm one of the EM faculty at the Yale School of Medicine. And I'd just like to start us off with a case that really grabbed my attention in terms of how important cardiac focus was to the care of our patients. So I'm going to tell you about a 35-year-old female who was a known COVID positive patient for about 5 days with a history of asthma and no recent exacerbations. Her family called the paramedics because she was having increasing difficulty with shortness of breath and started having some confusion. When the paramedics brought her to the ED, she was noted to be very cyanotic with no wheeze or rales, but extremely tachypnic with hypoxia to 50% on the non-rebreather, so high oxygen concentrations. And so a move was made to intubate her straight away due to her respiratory distress. And a situation no ED provider ever wants is when you intubate and you see the oxygen saturation start to plummet despite intubation. And so her oxygen saturations went to 40s, then 28, 18, and then 3, and then she coded. And when this situation arises, the first question is always, is the tube in the right place? Well, many of us had seen the tube go through the cords, and so we were absolutely certain it was in the right place. It does turn out that COVID patients obviously have very poor reserve, and so these plummets in oxygen saturation after or during intubation became quite common for our patients. And what I wanted to highlight here is this image is a subxiphoid image that is performed during compressions. So although maybe not a standard part of point-of-care ultrasound, many of us in the ED setting are using it to guide actual cardiac compressions, looking for compression location and adequacy. So anyway, this is an image performed during compressions. And then her next pulse check showed some activity. Nothing was showing up on her monitor, but when we looked during the pulse check, I'm not seeing very much squeeze. I'm seeing a very shimmering aspect of this. And so this was typical of what we see during VFib or VTAC, even if the monitor is not showing us those rhythms. So she got 1 defibrillation. She regained a weak pulse and started having some further activity. So this image on the right of your screen is now showing when she had a regaining of her pulse. And one thing you might notice is that we, or I'm performing echo in a different convention than cardiology. So it might appear flipped to you in some of these views, but this is my apical 4-chamber view. This is the left side of my heart, and this is the right side of the heart. And so I'm noticing some significant RV dilation, probably some septal bowing, some RA dilation, And now this is confirmed a little bit difficult with some TR that in a 35-year-old is probably acute. And so she was presumed to have a COVID-related coagulopathy that led to a PE that led to significant RV strain on our point of care echo. And I wish I had known that before we decided to intubate, because we probably would have handled the code a little differently. Ultimately, despite maximal pressors and despite giving her TPA twice, she did not survive. So very early on in COVID, it brought me to think about when the optimal time for us to perform point of care echo would be, and lessons learned about how to deal with significant and serious critical illness. So we'll talk about where echo gets inserted in pathways a little bit later. But for me, and this kind of extreme case, although someone's breathing is obviously compromised by COVID, I would echo before I decide to intubate so that I can have ancillary medications like TPA or like pressors given before the code can actually progress. So potentially during intubation, I would give these medications. And other things that we may have to think about in terms of room layout within a negative pressure room and the limited personnel in the room during a code, because we're not coding people with the gobs of ancillary help that we usually are used to. At max, we want 3 to 4 people in the room, including the respiratory therapists when a code happens, and where to place the code cart, the airway cart, and whatnot are things that we have to consider in those smaller rooms in addition to our ultrasound machine. So I just wanted to kind of show you what we're doing here. And, you know, in terms of scrambling to get a code card in place, a lot of medications being on shortage, pharmacy or pharmacists not available 24/7. Preparation, I think, is something that we were really considering with POCUS. And many of us ended up doing, like cardiologists upstairs, many of us ended up doing upside down POCUS, I guess, in which case we're completely backwards to the patient, just because that's how we can fit the machines in the room. And some places were also utilizing handhelds because they were much easier to maneuver, and handhelds could be assigned directly into COVID care rooms. We did not do that, but quite a few health systems were. This is not related to COVID. This is just here for people who might be newer to echo. If you'd like a couple articles on just the basics, there's one, the 5 E's that we use for just what we're looking for in basic POCUS, and another article written by Chris Moore that explains why some of the different cardiac general orientations exist and how we're using those specific image conventions. So POCUS for us really shined during COVID because of the following reasons. Really, there was a single provider that could perform all the aspects of clinical care in terms of history and physical taking, lab draws, and imaging through ultrasound without involving transporter or technician personnel, without involving you know, the portable X-ray techs and this kind of thing. And it would avoid us having to contaminate the fixed suites that would then take anywhere from 20 minutes to 45 minutes to clean. And so really we're just trying to save exposure by using POCUS. In general, what we were trying to do is establish the baseline respiratory findings and the cardiac function for patients. And we focused on all admitted patients so that should they deteriorate within the inpatient stay, at least the upstairs providers would have a baseline to fall back on. Our cardiologist asked us to try to actually get echoes on all admitted patients. I would say we probably successfully performed echo on maybe about 30% of all admitted COVID patients just because the volume was so high. But we ran into a couple of clinical conundrums in that sometimes, we didn't know their baseline function. If they had some pulmonary hypertension or even COPD, we didn't know if they had pre-existing RV enlargement that was associated with those diseases. And so how to really frame our findings within the whole context became kind of an interesting issue. But in cases where there might be more futility, for instance, a seriously ill patient with known COPD or known pulmonary hypertension with RV strain, it led us onto pathways where we could just basically treat rather than obtaining a CTA of the chest. And so sometimes it would lead to treatment decisions based on the clinical context and based on what we found from their point-of-care echo. For discharge patients, sometimes we could offer reassurance. So for example, if I had someone who's well enough to be discharged, I could say, hey, listen, you do have lung findings that are typical for COVID. You really should go get an outpatient test. You're well enough to stay home right now. And right now, also your cardiac function looks great. So I think you could do well at home. Please come back if you feel worse. But right now, your cardiac function is good. And we know you have signs and symptoms of COVID, so go get your outpatient COVID test. And a huge thing for us was avoiding anchoring onto COVID. So for instance, patients with severe shortness of breath, there was one patient who we thought definitely had COVID, needed to nearly be intubated. They were tried on BiPAP even, which we weren't supposed to do during COVID, but we did. And instead of it being COVID, it turned out that he had a huge pleural effusion and ascites and really anasarca from newly decompensated alcoholic cirrhosis that no one knew that he had. And so instead of going down the COVID pathway, we could put a chest tube in, alleviate that reason for shortness of breath, and he ultimately went to the floor instead of being anchored to a COVID diagnosis, intubated, and all that things. Just briefly, I wanted to highlight every single society has issued their guidance on transducer cleaning, machine cleaning during COVID. And so these are AIUMs. If you want to have a look on the AIUM website, and the ASC have also issued their protocols on cleaning and cleaning guidance. I wanted to show you how from the ED or kind of first line provider, we inserted POCUS into the care of a patient through our COVID algorithms. And so here, right from the very start, we said not all patients require labs or chest x-ray, but if you would like imaging, consider POCUS at this point. And then it's reiterated again when a patient is quite serious and needing admission. And so we had it there at 2 points with a sideline on what exactly we're looking for in point-of-care ultrasound and COVID. And it stresses decreased ejection fraction, and I'll get to that in a little minute, but really we're looking for also signs of pericarditis or myocarditis in terms of pericardial effusion, the squeeze, the RV, possibility for RV strain that's acute, dissections, and also some fluid management by looking at the IVC. There's a really nice algorithm done by, that you can find on Twitter, done by V. Din, and he's a critical care and ED double-boarded physician whose Twitter handle is @POCUS101, and through his POCUS101.com website, he put up an algorithm that are kind of like all the things that we would look for in the acute setting regarding echo and COVID. I personally include IVC as part of my echo in point of care. Technically, it's obviously in the abdomen, but I really want to know what my preload is, and so this is why I personally look at the IVCs. And we were doing this for fluid management reasons. So I'm kind of going to end here with another case, and we have one of my last COVID patients was a 70-year-old man with quite a few risk factors, and unfortunately contracted COVID from a healthcare provider spouse of his, and he was really laboring. And this is the initial EKG, which did not show any morphology changes compared to old. His troponin was negative. He had quite a high D-dimer and CRP and inflammatory markers. And if I'm looking at his POCUS here, you know, this is kind of typical of what you get. Some of the imaging is really limited, but I'm looking here. I'm not sure that I can totally comment on whether there's a truly decreased EF here, but I'm going to start getting a little puzzled by this region, which is maybe not quite moving as well as the rest of the LV. And so now I'm going to start wondering if he has focal wab motion abnormality changes. And now we move to his peristernal short axis views, again, quite limited in quality, but here is my LV. And, you know, if I'm picking a point here in the middle, this aspect of the LV wall is squeezing towards that middle point, but my septal anterior side isn't really so much. And here's another peristernal short axis view that it's very subtle, but I think it says the same thing. So this part is really squeezing towards the middle, and this septal anterior kind of almost anterolateral side is not squeezing as well as down here. And so I think this is new focal wall motion abnormality in someone whose initial troponin is negative. He was admitted to the ICU, at which point his troponin started to become positive, but we had already alerted the cardiologist saying, listen, I think we're starting to get someone that you may need to pay a close attention to. And so although it doesn't necessarily change ED management, it can change who gets earlier cardiac or cardiology review, and maybe who will need an earlier comprehensive transthoracic echo in the ICU or on the floor. And so someone who may decompensate. I just want to bring this up because one of the Yale cardiology groups did some review and found that LVEF was a significant risk factor amongst other risk factors in the morbidity and mortality of hospitalized patients. And so if we can flag those that have increased chance for deterioration and higher morbidity and mortality from the ED, maybe that alert can kind of really start changing some initial management. In order to enable some of this stuff, though, is we really need to have a system-wide and hospital-wide approach to imaging, image storage, and kind of imaging communications. So COVID really highlighted, it's kind of, you know, POCUS's day. COVID highlighted how much the hospital system needs to invest in communication infrastructure. And so here at Yale, we have some middleware software called QPath that stores all our ED POCUS images. And so these are the COVID ones that I placed in the COVID tag. And all these patients have documented and image stored kind of POCUS scans that everyone in the hospital can see. So once I complete this QPath here, it goes into, this is our EPIC EMR, where here are all the results of the echo. And so someone in the ICU or cardiology are able to look at any of these images that we took through our PACS or through our VNA system. And so this really is something that a lot of hospitals are now investing in, hopefully for the benefit of all of us. And lastly, I just wanted to summarize with a kind of decision tree on how we were using cardiac POCUS in COVID from the ED, and really focusing on the moderately unwell to critically unwell patients who would be reviewed by our cardiology colleagues later on. And with that, I'd like to turn it over to Dr. Thommen representing the ASE. Ritu?
Yeah, let me see if she may be running into some challenges.
Oh. I'm just gonna put this up for a quick second again, then just.
Perfect, thank you.
Just so that people can have a little bit more time to digest. I know I kind of ran through all that fairly quickly because I wanted to give her time to go through some of the more intricate nuances of some of these, but if you have any questions, please feel free to type in the Q&A. I think using POCUS, whether it's lung or cardiac, in terms of ultrasound scoring systems to try to predict severity is a very interesting idea. Some systems were able to obtain echo and lungs for all baseline admitted patients, and some systems were not able to do it at all. I think we sort of found a mix of both, but really when we found, especially for codes or very serious patients, you got to limit the personnel in the room. And so the leader in that room really had to be an expert in care management, be an expert in procedures, and be the expert in ultrasound. So hopefully that gives me job security, but we need many more people to be able to do this. And hopefully whatever we learn is indicated for future pandemics.
And we have a question already, so if you'd like to
oh, yes.
Address that while we wait.
Dr. Jaffa says, does anyone have experience folding EM-performed cardiac POCUS into a STEMI protocol? Interestingly that you say that. So yes, I wouldn't say it's a formal process, but what happens with us is if we call cardiology for a STEMI alert, and sometimes we get multiple of them at the same time, then they will always prioritize the one who has focal wall motion abnormality. So my consult to them is, get down here, please. You have a STEMI alert, but this person also has focal wall motion abnormality. Before the troponin rises sometimes, or for NSTEMIs that have focal wall motion abnormality, they are much more likely to take that person for an emergent cath rather than waiting for an elective cath. So, so it definitely plays into kind of triaging the people going to cath lab. I hope that answers that question.
Okay, and I'm still trying to reach Dr. Thurman, so I don't know.
I'm here, sorry.
Oh, there we go, yay,
I apologize, yep. I wasn't sure. So I can share my screen.
Let me stop sharing.
Thank you very much. And my pleasure to be here representing the American Society of Echo and this great collaboration, very timely and needed. I'm not sure why it's not letting me. I'm just trying to go to my next slide. And apologize for that.
Are you in the presentation mode?
Let me go in there.
There we go.
Okay, apologize for that.
Perfect.
So I will take many of my comments and my remarks from this statement that the ASC put out back in April, where we were making recommendations on what to do about POCUS during this novel pandemic. So some of these things have been gone over, but I would like to reiterate them because repetition is learning. So cardiac POCUS helps to triage the dyspneic patient and also helps to determine the need for subsequent imaging. In fact, a global survey that was conducted of about 1,200 echo reports showed that these cardiac abnormalities were seen in about a half of COVID patients, and that the imaging itself changed management in a third of those patients. So this comes directly from our guideline, which shows that when a patient comes in with suspected COVID, besides doing the history, physical exam, and the laboratories, which many times will include a troponin value, we'll go right to POCUS because we want to limit the exposure of other personnel and locations, and we want to conserve PPE. Now, mind you, this was written in April, but these still pertain. Now, there are some limitations to that because the POCUS may not have exactly the imaging resolution when we compare it to a more comprehensive TTE. And sometimes based on operator experience, we can miss findings. And we also have to make sure we can archive this because we want to be able to look at a POCUS that perhaps was done earlier and compare those findings. What we have seen recently is that the number of limited TTEs, this is based out of University of Chicago, have greatly increased. And we see this over both inpatient and all comers. And this is an enormous stepping stone for POCUS and POCUS users, as all of you in this audience may be aware of. So what are we looking for when we're doing a cardiac focus? It has to be very goal-oriented. We want to do this because we're trying to detect either new disease or characterize maybe pre-existing CVD. As we know, many of these patients with COVID have underlying cardiac disease, at least 20 to 25%. Sometimes we do POCUS because the status of the patient is worsening and we want to make sure that there's no abnormality from the heart. And sometimes it's just monitoring and just examining. So what we use this for is to make sure that there's not a pericardial effusion or myocarditis. We can look for wall motion abnormalities and ischemia. And sometimes we can see a Takatsubos and RV failure in PE. And I will go through these now. These are also, this image is from our guideline, which breaks down the images and the structures that we have to use. So in the LV, we want to look at the size, and we want to see global and regional function because we're trying to see, is this myocarditis? Is this acute coronary syndrome? And how fast is this person possibly going to go into shock? Sometimes we are able to see that. We will look at the RV. We also will evaluate size, function, and look for tricuspid regurgitation. Possibly, you might even see an embolus. I will show you an example just down the road. And of course, we look at the pericardium to see if there's an effusion, and tamponade is a clinical diagnosis, along with confirmation of changes in the heart. The valves, we look to see if there's regurgitation or stenosis. Sometimes in this guideline, we have just recommended either yes or no, because we'll have to go on to more advanced imaging to see more clearly. Here are some examples of this. Parasternal long axis view, you can clearly see the RV and LV. You can see the mitral valve and the aortic valve and LVOT, and the apical views as well. And most often we're able to get short axis views, both parasternal and sometimes an IVC as well. if you go up an intercostal space from the parasternal long and you just shift a little bit laterally towards the left shoulder, sometimes you can get a nice image of the aortic root, and sometimes you might even be able to catch a dissection. So what are the findings that we find, cardiac findings in POCUS? We find people coming in with just regular acute coronary syndrome, both STEMIs and non-STEMIs. We see acute myocardial infarction without any obstructive coronary disease, which really represents 3 major buckets. One, myocarditis. Another one, COVID-related cytokine dysregulation, and either a stress cardiomyopathy or a Takotsubo. Sometimes it's very difficult to tell those apart. I'll go through those. You can also see arrhythmias. Sometimes a person is actually in heart failure, and you can of course see effusions, sometimes also thromboembolic phenomena. The cardiac involvement in COVID is diffuse. It can be direct viral cardiomyocyte toxicity. It can actually be vasculitis with microvascular dysfunction, like a Takotsubo, which is stress cardiomyopathy. You might also have either just a pure type 1 myocardial infarction with plaque rupture. And many times we're seeing this oxygen supply demand mismatch from hypotension or tachycardia or metabolic demands if someone is septic or hypoxic. Troponin is the biggest predictor of death. It is even after 6 months of being in this pandemic. And so if there is an elevation, and you can see that there is actually a stepwise increase in mortality depending upon the level of your troponin. And this is a beautiful chart just showing if you have myocardial injury, which is just a term that applies for that your cardiac troponin concentration is above the 99th percentile. Sometimes they're chronic conditions, and that shows that your troponin hasn't really risen by more than 20%. Those are people who have chronic conditions. That is to be differentiated between acute myocardial injury, which goes both as a primary cardiac illness, but we are also seeing primary non-cardiac illness, like sepsis or pulmonary embolism in these acute COVID patients. And make sure to keep that in mind. And if we do have an acute myocardial infarction, again, there's either supply-demand mismatch or an acute coronary syndrome. In our POCUS guidelines, we have this beautiful table that just reviews the steps of keeping this cleaning checklist in mind in both suspected or confirmed COVID infections. And make sure that you know your wet times for cleaning and disinfecting agents. Those are variable, and use drape as much as you can, and barrier devices, and limit the equipment that you bring into the room as much as you can. That's less cleaning for you down the road. So when we perform POCUS in these patients, we are going in there determined to answer the clinical questions, very much goal-directed, because we want to adjust the protocols to minimize the length of the exam. And we want to get the best quality images, obviously we can. And sometimes, in our case, we do go in prepared and make sure you have supplies. If it needs to go from a POCUS to a limited transthoracic, we recommend that you bring in ultrasound enhancing agents, because it has been shown to decrease study time and make a quick diagnosis. In addition, it is important to have some kind of system where you will store and archive and document your POCUS results, because sometimes you may have to go back and look at these images. And of course, this helps to reduce the need for repeated scans, because if you can't find the past POCUS ones, that just leads to using up more of your PPE and risking your exposure again. Sometimes these patients are in prone position, and we have to use a swimmer's position with the left shoulder elevated with the pillow. So we have space to put the probe there. And this is a beautiful image from a study that was published in 2018, pre-COVID. So in these patients who come in, one thing for sure is we want to see, do they actually have a normal exam? And in fact, about a quarter of them will have just normal. And these are, those are these images that show just normal LV function. Sometimes we have seen hyperdynamic LV function because there's an increased cardiac stress response to the inflammation that is going on from these COVID patients. Sometimes they're also very high preload from fluids that they're getting, or their peripheral vascular resistance is decreased, and you'll see this hyperdynamic function. Make sure, if you can, also to look at the LVOT. Sometimes when we actually vasodilate, patients can become hypotensive if the LVOT is obstructed. And that's just something, a clinical pearl to keep in mind. We are also seeing Takotsubo's cardiomyopathy in all forms. And the classic one is seen here in this patient, where you have this apical ballooning where the base is still coming in nicely, but you see this enormous amount of apical ballooning. In this patient, we happen to have an echo pre-COVID, which showed that the apex was coming in beautifully. Now, here's someone who's having an acute myocardial infarction. Now, this can be both type 1 or type 2. The cytokine storm, the increased level of catecholamines, sometimes microvascular dysfunction or even spasm can give you this. And this is an example of using ultrasound enhancing agents, again, because we now spot this thrombus that is really hidden. We can't see it in this without the ultrasound enhancing agents. I must say that there are many POCUS companies now trying to be the first one to be able to, so we can use these with POCUS itself. The most common thing that we're seeing in these COVID patients is RV dysfunction that's acute. Both in here you can see that the RV free wall is just lagging. It's really not coming in at all, but the apex, as you can see here, is coming in. Sometimes this is called a McConnell sign, which means that the RV dysfunction is probably acute, because this McConnell sign comes from a doctor who was actually a trainee in 1996 who published this results where they just were looking at chronic patients with pulmonary hypertension versus people who were acute. And this was really much more sensitive for picking up acute dysfunction. And of course, we want to know the RV dysfunction, because Kaplan-Meier, this is a beautiful study that came out of Wuhan that shows in blue, you see here, if you have RV dysfunction and your troponin is positive, your survival is significantly decreased as compared to those who do not have RV dysfunction, and certainly those whose troponin is normal. And there's actually a higher prevalence we're seeing of RV dysfunction, probably from the ARDS, the hypoxemia, and the pulmonary microemboli in these patients. Here's a beautiful example that I found of this clot in transit. And as you can see, the RV is also dilated and hypokinetic, and you can see the amount on color Doppler of the tricuspid regurgitation. This was published in JACE out of New York City early on. One thing to keep in mind when you are looking for pericardial effusion, remember, you want to get the largest width at the end of diastole. And of course, we're using a single linear measurement to quantitate the size, and make sure that you're getting the whole view. So look both the apical forward chamber and look at the subcostal views, because there is actually a correlation between the amount of effusion and prognosis. So another thing that has come up is myocarditis in these patients. This is less common as we first saw, but I wanted to just highlight the difference between both a fulminant type, which is sometimes what we see in these patients. They're coming in, they're very sick, and they're either in shock or they're just about to go into shock, or more of a fulminant type of myocarditis. And versus somebody who has an acute, which is more over a length, they've had a viremia for a longer period of time. And you have to look at the LV internal diameter in diastole and see, is it increased or is it normal? Because when they first come in fulminant, this diameter is not going to really be increased. And we're also looking for LV wall thickness, with which in a fulminant picture actually increases because of the amount of edema. You see all this interstitial edema. One caveat is look for this in the septum and in the inferior lateral walls. But remember that this LV wall thickness can be normal on the first day that they present. And then you can see this incredibly fast progression over time. And that's just something to keep in mind. So if the thickness, the wall thickness is normal, it still can be a fulminant myocarditis. You'll just have to keep the patient's clinical picture in mind. So in the event that you still don't have a diagnosis, or you need to know if this person has Takotsubo's versus an acute MI, because you have an apical wall motion abnormality, then a limited TTE with ultrasound enhancing agent will help you. This contrast is very important, because these bubbles, or contrast, it's really should be used, the word should be used, ultrasound enhancing agent, but the agent itself are bubbles. And we give a quick burst of energy, and then we watch the bubbles replenish. And the rate of the bubble replenishment actually is a slope, and that rate corresponds to myocardial blood flow. So in Takotsubo's, that blood flow is normal, but in an acute coronary syndrome, you're going to see an abnormal perfusion abnormality in the area of the apex, and that's what we're seeing here in this image. Here's a case of a man who had COVID from Wuhan, and he presented with typical high temperature, and they could not see anything on his CT, although his BNP was elevated. And then you can see on POCUS, you see this enlarged left ventricle, you see a diffuse wall motion abnormality, and you see an EF that is reduced at 32%. And here on the color Doppler, you can actually see that there's a significant amount of aortic regurgitation. And this were typical patients that were coming in Wuhan early on in this disease. And in this patient, the RV was size was normal, and lucky for him, he did do well and survived. Now, one other aspect of COVID that comes up with us doing POCUS is that there's collateral damage. So while there are the patients who have COVID that are coming in, many of these patients, cardiac patients, are avoiding coming to the hospital. And we can see this data that shows a 4-fold increase of cardiac arrests compared to the same time period a year ago. And at peak, 4 times the amount. And so these patients are not coming in. They're afraid of getting COVID in the hospital. So they're having their STEMIs at home, and they're having their arrests at home. And so when they do actually come into the hospital, what we're finding are incredible pathologies that we have not seen in this amount for many, many years pre-PCI time period. So we're seeing VSDs and we're seeing free wall ruptures in larger numbers than we've ever. Here's an example of a VSD. You can see the color flow across, and here there was an acute papillary muscle rupture and this wide open mitral regurgitation in a patient who was delayed in coming in to the hospital. So thank you very much for listening. These are some references. I am available for answering any questions, certainly online and on Twitter. There are many, many discussions around these topics. In addition, there is also a POCUS journal that is highlighting many of these, as well as, of course, American Society of Echo and JACE and CASE. So thank you very much for your attention.
Thank you, Dr. Thalmann. And I do believe we have at least, there we go, we do have some questions coming in now.
Okay, so one of the questions is somebody's asking, by ultrasound enhancing agents, do you mean a contrast for ultrasound? No, it is not contrast. And this was a big issue with the FDA. Originally, the term contrast was used. That was back in the 90s. And subsequently, because it's not contrast, it's not what you typically get when you're getting a CT. This is ultrasound enhancing agent. It's been rebranded and renamed. So you'll see this in the literature as UEA, short for ultrasound enhancing agent. Basically, they are bubbles and they have no toxicity related to what we associate with contrast, like anaphylaxis or renal insufficiency. So that is very important to remember, because if you're doing a POCUS, but you haven't been able to answer the cardiac question that you really need, then you're going to go, the next step will be to go to a limited TTE. But you want to use an ultrasound enhancing agent to make the correct diagnosis, because the images are substantially better, as I've showed you in this presentation. I hope that answers your question. So the next question is, are these cardiac arrests related to COVID-19 or or standalone post-MI complications? That's a very good question. I don't believe that that answer has been fully worked out. What we are seeing in the post-cardiac arrest, now granted, 90% of cardiac arrests do not even make it into the hospital. So we're seeing a limited amount that are, for whatever reason, lucky enough to make it into the hospital. At the time when COVID was really high numbers in New York City, people, weren't made, the ambulance couldn't even get there in time. And so, but what we were seeing were delayed STEMIs, and not only in New York City. Mind you, in March, we had a publication in Circ Outcomes from Hong Kong that showed the delays in STEMI presentations in Hong Kong. Subsequently, we've had publications from Europe as well, demonstrating the same thing, because the human fear factor is universal, and people are just afraid to come in and they're suffering at home. And part of the message that we want to get out is, if you are having chest pain, if you are having cardiac symptoms, please do not wait. If you're dyspneic, please come to the emergency room. We've learned a lot about this disease in 6 months' time, and we're much better at controlling the infections. Any reason to select one UAE over another in COVID? No, whatever you have in your hospital, there are different ones that are approved, Lumify, Optisom, Definity, and those can, whatever your hospital has contracted with should be used. And I think that's it. I don't know if there are other questions.
Rachel, I'm just going to kind of reopen one that was asked earlier. And someone asked regarding kind of EM performing POCUS in terms of STEMI protocols, specifically for COVID. And
Okay.
so I'll just read what he said just because it's in the answered pile.
Okay.
But basically, a person works in a small rural ED and needs to transfer for any STEMI alerts. And they had proposed a protocol where a STEMI alert would go out and then an EM attending would perform the POCUS. And if it looked like a COVID-related cardiomyopathy, they would go the COVID treatment route. But if they were afebrile and POCUS looked like a classic STEMI with maybe new focal wide motion abnormalities, it would get activated to fly to the cath center. And he was just wondering if any, if you know of any like protocols or anything like that for more like remote transfers regarding STEMIs during COVID.
That's an excellent question. Pre-COVID, there is substantial data that shows telemedicine with the EMT for patients who are having non-STEMIs or STEMIs actually reduces door-to-balloon time and has really impacted care where it's been done. In the rural population, I have not read of a study, like certainly even observational or randomized control study that actually has looked at this. But what has come to the attention is we are not, even with using POCUS, we are not always sure if the person is COVID positive or not. Because many times the patients are asymptomatic from a COVID point of view. If you go down the checklist of, did you have a fever? Did you have shortness of breath? Did you have a change in your taste? Those sort of specific questions for COVID or non-specific questions for COVID. So there's patients that if they're having an acute MI and you see a wall motion abnormality, if you're doing a POCUS in the field, or you see something that looks like a diffuse picture, more of a myocarditis, either way, they should be taken to the cath lab, in my opinion, because the outcomes are superior. But we treat everyone, in full garb and assume that they have COVID until proven otherwise, even though that the prevalence of disease in many different communities is quite, is low, and certainly in the rural population. But I can tell you that the rural population prevalence of COVID is increasing. So.
Maybe just a follow-up question from me. I know, especially at the very height of COVID, our cath labs, were fairly closed because no one really knew how to handle the kind of invasive procedure with COVID yet. And so we were really reliant on the nasal swab for it to come back either positive or negative. But even, the question of negative COVID swabs still being COVID PUIs and then taking to cath lab was kind of an issue. So I was just wondering how you guys did it and whether things have sort of relaxed now that people know a little bit more.
It still takes us, unfortunately, more than 4 hours to get a result. Some people, some places it's much faster, and now the point of care testing is becoming more available. We don't have it here yet in Pittsburgh, but other places do have that. And that will be somewhat of a game changer, I think. So we'll know more quickly, because waiting 4 hours when someone's having STEMI is just not, it's prohibitive, right? So we can't wait. So we are still, we just go with the protocol where, it's a regular, we treat it like a STEMI. The numbers are still down overall because people are waiting and they're afraid to come in, even with their STEMIs, even to this day, because the fear of getting COVID when they come into the hospital is strong. And we're just seeing so many of these complications that we haven't seen in this amount in a long time. decades.
I think for us, our quickest is 2 hours, a 2-hour test, which is even past the 90-minute metric, for cath lab activations. And so I didn't know if initially anyway, there was a thought to doing more medical management, like kind of old style way, before cath lab or in place of cath lab.
Yeah, well, in Wuhan, the original place where this started, they went back and started doing TPA. So nobody went to the cath lab. Everyone who was having a STEMI or non-STEMI, they just gave TPA. But we know from so much data that we end up with TPA failures, and then we end up taking them to the cath lab, and then their outcomes are far worse. So we didn't go that route here. But in many, many parts of the world, that's where they've reverted to that. And so that just, we'll see what the outcomes are, long term, but we don't think that those are going to be as robust as if you just take them, to the cath lab and just guard. If you have enough equipment, that's always the issue. Do you have enough PPE to be able to protect everyone? And those who have enough gear they're not getting infected. Even by the end of the pandemic for Wuhan, they revealed, we had a webinar with them at the ACC in March, and they said once they figured out how to gown up, they had amongst 32,000 patients, there were no doctors or nurses were getting infected. So that's really great result. Yeah.
Well, I think I don't see any more questions coming in, and we're kind of at the top of the hour. So I want to thank everybody on behalf of the AIUM and the ASE. Our thanks to today's speakers and all of you who participated today. And I'd like to remind you that a recording of this webinar will be available on the AIUM website. We hope you'll join us again in the future for additional webinars. Thank you, everyone.
Thank you.